see. There we go. So for those of you not familiar with San Mateo Medical Center, I wanted to give you a brief overview. This is a beautiful photograph of our main campus medical center, and our mission is to open doors to excellence in healthcare. This is a visual of our integrated system of care, and as Dr. Chang mentioned, we provide ambulatory care, medical, surgical, acute care, psychiatric care, long-term care, ancillary services, of course. And then at the bottom, we highlight some of our unique services, including the Ron Robinson Senior Care Clinic, the Innovative Care Clinic, which you'll hear a lot more about, and our Keller Center for Family Violence Intervention. Really, what we do the most of is ambulatory care, and this is a map of San Mateo County, and you'll see our clinic sites are distributed throughout the populated areas of San Mateo County, including in the North County, in the Central County at our main campus, in the South County, and then on the coast side in Half Moon Bay. This is another way of looking at what we do. We are I would say an unusually collaborative county. We have very close and tight working relationships with the organizations and the groups of organizations you see represented on the screen. So in the middle is the health system. San Mateo Medical Center is about half of the health system, and we work very, very closely with our colleagues in behavioral health and recovery services, aging and adult services, public health, and family health. And those close and tight relationships are critical in many ways to us achieving our goals for the medical center. We also have a county-organized system of healthcare here. So the health plan of San Mateo enrolls all people who are eligible for Medi-Cal. It has a product for people who are eligible for both Medi-Cal and Medicare. And the health plan of San Mateo for the last 5 years has served as the third-party administrator for our Indigent Care Section 17,000 program, which we call here ACE. We work closely with the one federally qualified health center in our county, Ravenswood, which is located in the South County, Samaritan House, and RotaCare, which are voluntary clinics. We have two healthcare districts in our county, the Peninsula Healthcare District and the Sequoia Healthcare District, both of which are involved in providing care to people who are underserved in the community. And then last but not least, we work very closely with our community hospitals and physician groups, and we have hospitals that are part of the Sutter system, CHW, Daughters of Charity, Kaiser, and then the Palo Alto Medical Foundation, which is a large integrated medical group. And we really do work closely with all of those organizations to provide care to the underserved in the community. This just gives you a very high-level view of our volume. So it really just shows you that most of what we do is clinic visits, and we also have a very large presence in long-term care. These are our patients. So last year, 78,000 unique individuals were served. A little more than half women, about a third under 18, and a little more than 10% over 60. We have a very large Hispanic population, and besides Hispanic and white, we serve people who come literally from all over the world. About a third of our patients are on Medi-Cal, a third are ACE, which is our, as I mentioned, our Section 17,000 program, and then they are scattered around the county as we show here. So where it really comes all together is in our strategic goals. We developed these goals in conjunction with stakeholder groups in our organization about 9 months ago, and they've really become the focus for all of the work that we do. And you can see that right in the middle of this is our quality and safety goal, which is quite aspirational. We want to be recognized as the best integrated delivery system in the country by 2015. Now, of course, we can't do that without the other four goals around it. In terms of patient experience, we want to be the provider of choice, the medical center to which employees would want to take their loved ones, their families. We need engaged staff to do this, and we'd like to be the healthcare employer of choice for people, especially in our community, who are committed to serving the community. In terms of financial stewardship, what we really want to do is be a high-value provider. That means high quality at efficient cost. And then community partnership is also a big goal for us, as I described earlier, working in conjunction with all of the groups in the community who provide health care to serve the underserved. So I wanted to just tell you, now that you have a sense of our system as a whole, I wanted to talk to you about the beginning of our transformational journey. And it really started in 2004. It started with one collaborative, and at that time the collaborative involved what we called the main campus adult primary care clinic, which has now evolved into the innovative care clinic, in which you'll hear a lot more about. It started with this one clinic. There was one team, one doctor, one nurse, and one medical services assistant, one diagnosis, which was diabetes. We had 100 patients, and we had one registry. Here on this slide, you'll see described not all of the collaborative projects and improvement projects we've been involved in, but some of the more important ones. And I'll just show you, I'll just point out a few. Primary care redesign has been an important journey for us. And most recently, we have culminated that in the Senior Care Initiative, which has involved all of our clinics, including the Integrated Care Clinic. The other thing that I'll point out here is our ambulatory electronic medical record. We started on this journey implementing the EHR 2 years ago, and we're still in the process of perfecting it, but it's been a really important tool for us to really move to a place of managing populations. But you'll see a lot of different things here, and I'm going to talk about some of them in particular when I point out our lessons learned. It certainly isn't all roses out there. There are many challenges that we face even as we really try to focus on our goals. We, like every other community in the state, have issues with our local budget. We have a structural budget deficit, and in fact, we're going to be presenting our budget proposal for the next fiscal year just next week. The state budget has huge implications for us that we haven't even fully quantified at this point. And of course, we don't really know what the federal budget has for us, but it possibly isn't so great. As we prepare for 2014, which is when the Affordable Care Act really comes into full play, we know that we need to reduce our costs, provide exceptional quality, and provide the optimal patient experience, which of course is the triple aim described by IHI. We need to become much more involved in predicting and managing our external environment. There are a lot of changes happening with private physician groups and hospitals that affect us, and we need to be fully engaged in that and understand the impact that has on us. And then last but not least, recruiting and retaining exceptional leaders and staff is always a challenge. We're really lucky to have some exceptional leaders, including physician leaders, and we just need to continue with that. So what are the lessons learned? I think this is something that many of you may be interested in. How have we accomplished some of the goals that we've set forward for ourselves? And I wanted to give you specific examples of these lessons. So the first lesson is having a vision and goals from which you are undeterred and undistracted. This is hard to do, and the first issue really is setting the long-term goals, and I went through these for you before. We haven't been so focused as an organization on goals and really having measurable objectives that are attached to those goals, and even beyond that, having departments who have their own goals that reflect the organization goals. That's been really critical for us, and it's been a process that we're still trying to learn and perfect. In terms of the second one, it's everyone's responsibility from leadership to line staff. The one example that I want to give to you on this is the work that we did with the Integrated Nurse Leadership Project on sepsis. And here, this is a collaborative project that probably some of you have participated in. It was really well done, and it's focused on reducing mortality from sepsis in the hospital. And we have a team involved in this, but when we really started making traction here was when we got a group of key physicians from the our inpatient area, from the emergency department, really engaged in the project and really taking it upon themselves to talk with physicians about accomplishing the goals and directives of that collaborative, and that's when we really started seeing results. So that physician leadership involvement was really critical. It wasn't enough just to have line staff like nurses and other staff involved. It was nursing leadership and physician leadership that really made that happen. Impossible without everyone's dedicated involvement. As I mentioned to you, since 2004, we've been working clinic by clinic on really perfecting the medical home, on doing primary care redesign. And I think where we really did well was over the last year when we were involved in the Seamless Care Initiative, which was doing really patient visit redesign across every single one of our clinics. You will see evidence of this when you see Dr. Haddad's presentation, but moving to a place where every single part of the organization is involved in improvement is important, and I think the Seamless Care Initiative was a good example of that. Impossible without staff involved in teams outside of traditional silos. The example I'll give you here is the work that we did with lean process improvement, and specifically we did an improvement project that was focused on reducing all-cause readmission from congestive heart failure. The thing that I loved about this particular project is that it engaged staff across silos. So, for example, it engaged staff from our emergency department, from our ambulatory clinic, from our inpatient area, and long-term care, all different types of staff from all of those areas that were focused on the single measurable goal of reducing readmissions from CHF. And it really has worked for us. And in fact, over the past years, we've had many months where we've had 0% readmissions for CHF all cause, which has been really important for us to see. In terms of focusing on measurable outcomes, we have lots of examples of this. I think one of the most memorable examples in my mind of where we first started doing this was when we established our chronic pain management clinic. And this was several years ago when we weren't really in the habit of measuring outcomes. And we ended up doing this because the Board of Supervisors told us that they wouldn't give us the money for the clinic unless we started measuring the outcomes. And we found really how powerful that was, because when we started tracking those patients' use of primary care, emergency department, specialty visits, and quality of life, we noticed that the pain clinic had a measurable difference on people's lives. And that was very powerful for the organization to see and helped motivate us to do more of it. In terms of taking advantage of many opportunities, we've done about as much as we can of taking advantage of all different kinds of collaboratives that touch all different parts of the organization. And I think now where we're really looking ahead to is having a more unified focus on process improvement, and where we're moving toward doing that is in lean process improvement. In terms of constant test of change and failure, I think the best example we have of this is the Care Transitions Project, which is focused on reducing readmissions of all kinds. We started this project in 2007. We tried many different models for doing it. We experienced many different failures, and I'm happy to say that now we have a model that we do in conjunction with our health plan of San Mateo that really works for us. But we had to suffer through many different kinds of failures and be very persistent until we finally got to the end and were successful. And then in terms of the long journey that requires constant vigilance, I think the best example of that is the ICC. It started in 2004 with that one team, one diagnosis, 100 patients, one registry, and it's really evolved into an incredibly successful 21st century medical home model of care. And with that, I will turn it over to Dr. Evelyn Haddad.
Thank you very much, Dr. Ehrlich. Thank you. Thank you again. So my name is Evelyn Haddad. I'm going to talk a little bit about the Innovative Care Clinic. First, I wanted to share with you our mission statement. The Innovative Care Clinic uses the team approach and strives for high-quality care that addresses total health with emphasis on self-empowerment, education, prevention by improving access and efficiency. So this is something that the staff we came up with as we were coming to actually redesign the Innovative Care Clinic. So as Dr. Ehrlich was saying, in 2004, the Innovative Care Clinic started to exist in some form. And then around April 2008, a group of physicians, MSAs, PSAs, so everyone from our clinic came together representing our whole clinic and decided to really finalize how our primary care model is going to come up. And things that these are kind of the features that we have in our clinic. So one thing was the team-based care. Every member of our staff belongs to a team, and also a patient belongs to a team. And the team-based care really is emphasized by we have colors to designate every team because it's not per provider. It really is the yellow team, the green team, and the blue team. We have a lot of support staff that I'll go into a little bit. We expanded how patients interact with the clinic itself. We used technology. Being in the Bay Area, we really had technology on our side, and we used it to have different ways to communicate with patients and also to access help to patients. Open access, so patients could have access to the providers and to the team. And then we always focus on health promotion, education, and then, of course, performance and outcome measurements, because if you do all this work and there's no outcomes and no change, then we have to readdress what we're doing. So first I'll talk about the team case care. So we formed pods, and these pods are, again, as I said earlier, they're based on different colors, and each patient belongs to a pod. In each pod we have which sounds very easy as a conclusion, but we had 2 providers, 1 nurse, and 2 medical assistant, and 1 clerk. And even that, something that simple took a lot of thinking about and redesigning, and that's what worked best for our clinic. And that's the pods that we have here. With the expansion of pods, with the pods formation, we had to expand what staff did. And the way we did this was, as we said I said in the beginning, we had a group of people from the staff people, and they actually would write down what they did, what they think they should do, and what different activities and roles they wanted to do in the future. And so really taking the feedback of the staff when we made the extended staff roles was really important because this is their input, and that way some roles shifted a little bit in our clinic. And to effectively use the teams. So I think the main way to do this is also the patients also have to identify with a team. I think it was a shift from the patient would identify with a provider, and now they have to really identify with a team. They get to know their nurse, they know their medical assistant, and they know who to call to make an appointment. And so they realized that they were part of a team, and it was not just the provider could answer the questions. And then regular meetings and huddles. Initially, every month, the pods would meet together, coordinate what needed to be done, how communication was going to occur, and now it comes to huddles every day with your MSA, how the day is going to go. Again, the key role is the communication and always keeping that communication lines open. And then outside the teams, we have a support staff that really does add a lot to to help manage our panel of patients. We have a diabetic educator whose role constantly expands and changes. Currently, we're having her do protocols, adjust medications via protocols with very little interactions with providers. We have a nutritionist that we can refer our patients to as nutrition affects all the range of health. We have a pharmacist that doesn't only help with medication education to our patients. She's also in charge of a lipid clinic. And again, really by having patients see her, understanding what the medications are for, we've shown great reductions in LDLs with our diabetics and also total cholesterol for all of our patients. We have psychologists that we could always refer to because, again, our patient populations may be very tied to depression or anxiety that may actually contribute to their health a lot more than what medications we could do. And then volunteers are really helpful because a lot of the times we have little projects that we need someone to do, and our volunteer access and input has been really helpful through the different times of change. And of course, IT staff to collect the data is something that's very important as well. So how do we expand the patient interactions? So other than the provider interaction day-to-day, we have group visits, especially for our diabetics. We have telephone visits where our RNs will reach out to our patients regarding a follow-up that the provider may need. And then we have panel management where every provider has a panel, and we either manage them through our medical assistants, and we're hoping to expand the role of panel management in the near future as well. And then technology. One of the main technology advances that happened in April 2009, right when the Innovative Care Clinic started, was we had an electronic medical record. So we had to reshift how communications could occur, but it was also a great tool to really have communication occur instantaneously. So that was something that, as much as it's a challenge, I think it was also a very positive thing in our clinic. Walkie-talkies, every staff member has a walkie-talkie, so we don't need to look for different staff to help us do things throughout the day, to cut down and become more efficient. We have the healthcare interpreter network because a lot of our patients may speak a different language than the providers or the medical assistants. For our diabetics, we have digital retinal camera screening that occurs on site to, again, get the yearly screening. We have teledermatology, access to a dermatologist within 24, 48 hours. Again, all these different ways to help provide better care for our patients. And then last year we had open access, part of the Seamless Care initiative. And so part of open access was to get ready for open access. And this started several years ago where we had a panel of patients, and every provider has a panel of patients that belongs to them. And our goal was to have same-day access to the provider team. So if a patient calls and needs something done acutely, they could be managed and taken care of. This took a lot of work. The main aspect was redesigning the phone tree. If the patients can't get a hold of us, then whatever system we had in place would not be helpful. So really having the phone tree so the patient could call and a nurse or a clerk or a medical assistant can answer them in a timely fashion, so they didn't look for other places to have their problem solved. And then to improve our no-show rate. So really if a patient has an appointment to come see the provider, there's no wasted time for providers. The other aspect is we're trying to promote health and education. So we had providers educating the medical assistants, the clerks, with brown bag lunches. And it was really, the first time we did it, it was really eye-opening because the clerks, they're in the medical field. They have family members who are asking them about diabetes and hypertension, and they were getting educated, and they felt empowered, and then they felt more empowered to be in the front, answer questions regarding, yes, you do need an appointment, or did you make sure you did your blood work before you saw your doctor? So it was just a great empowerment thing that the staff feels like they are part of the healthcare system. Nurse visits where the provider doesn't even need to be involved because it just needs a nurse either for blood pressure or for a different, just short H. pylori treatment, different little visits that doesn't really need a provider's input. Medical assistants providing the information. I think as a provider, we would, in the end of the visit, spend 5-10 minutes to tell the patients, where to go for lab, where to go to pick up their medications. So we had information sheets, and the medical assistants would answer all the questions. And so the patients have learned to ask the medical assistants as they're checking them out where to get all this information. Again, having the time for the providers become more efficient. And then patient set goals. When they see the diabetic nurse, they see the our pharmacist, they see our nutritionist, really kind of educating the patient of what they could do to really control their disease. Because again, this is a team and they're part of the team. As stated before, if we can't measure our outcomes and see if we are improving, then that's, I think, the most important tool, to always have some kind of way to measure what you're doing and seeing what kind of impact we have. So these are some of the measurements I'm going to share with you. So capacity, so how much a provider is seen, and again, you can see as the time has progressed, our providers all see their full day is their schedule is fully impacted. They see all the patients. They are able to take care of all the patients because we have the support staff, and patients usually come with all their blood work done and all the necessary tools that needed to be done before, so that as the patients come through our clinic, our providers are not sitting there waiting for things to happen. The providers are able to help their patients. The panel size, this is with a 4.0 FTE in our clinic, has expanded over the year. Again, our amount of patients in a panel that we could take care of has expanded because of the support staff and because of the increased efficiency in our clinic. No-show rates, even further back, it was a little bit higher. As you can see, continues to decrease now down to approximately 6%. And in a day, we may have 1 or 2 patients not show. So no wasted time, again, on the provider's standpoint. And this is something that I'm really proud of. Even prior to this, we had probably over a 20, 30-day no-show rate, a next available. So a patient calls for an appointment, they had to wait a month. It's not a really great system to try to deal with acute issues, or even have patients who are maybe excited about their diabetes come in and see us today because they're worried about it or concerned. And so now we actually have their next available down to 2 to 3 days, where a patient could call and they could see any provider that day, but if they wanted to see their specific provider, at the most they would have to wait 2 to 3 days. This is a third patient who would call on that day. So most could see their own provider that day or the following day. And as we are expanding the capacity in ICC, the one thing we wanted to make sure was that not more patients were going to the emergency room because either they weren't getting a hold of us, or maybe they felt like not in touch with our clinic. But again, our patients are coming to us, so they're not going to the emergency room. So less percent of our panel patients go to the emergency room, hoping that we could take care of all their acute issues that comes up. And then hospitalization rate has stayed the same because, again, I think we are capturing our patients and they're not getting sicker. And even if we're expanding the amount of patients that we see in our clinic, we're still able to keep them out of the hospital. So challenges. So I think the first challenge is that change is difficult, but I think it's also kind of an opportunity because to take the opportunity whenever someone says this is difficult or there's a challenge about some kind of change that happens, to listen to what their concerns are and then really take into consideration, because their concerns, even though the change might be difficult, is going to be valid. Whoever the staff or the provider who does the day-to-day work and may have a different perspective than some of the core people that made the decisions. So even though change is difficult, I think also understanding to listen to the reason why it may be difficult actually may give you an insight to change the system or kind of make a different process work. And if the process doesn't fit the clinic, change the process. I think that's the key thing. I think at times we've learned where, well, this is what works for everyone else, and then we try to do it in our clinic, but it really doesn't fit our clinic. And so this is where the feedback from the staff members really does help. And then when the process is done, then make the minimal exceptions, because I think if you have a process down and then you have an exception for one provider, one medical assistant, then it's not really a process in the clinic. So that's why it is really important to get all that feedback from everyone in the staff and the members. And then the EMR implementation. Again, I think it's a challenge. I think initially a lot of our team-based work had pushed back to the providers. And then it took a little time, but I think now it's back to the team-based model. But I think if you are going to implement EMR, which I think is a great tool, and it should be implemented, I think it's a great tool that's actually made us more successful, it does come with some challenges that you would have to kind of think about. And then keys to success. I think without support from administration, it would not have succeeded. Providers had to take time away from seeing patients. Charge nurses were taken away from doing their duties. So again, I don't think if we didn't have administration support, there would be success in our clinic. And then engaging early adopters. I think one other key aspect is there's always someone who's excited about some kind of change process. And if you have them be the first one who does it and is excited and is kind of the one who kind of tells all the other staff members and shows them how it works, then it goes like wildfire, because then you have 2 people excited and then you have 3 people excited, and it really does make change a little bit easier. The other key thing is not to have the same person always be the early adopter, so try to switch the staff members. And there's always they're all in healthcare for a reason, so they all have a passion about it for whatever reason. So having the charge nurse understand the staff, or the charge at the PSS in charge of the clerks to know what causes them to be passionate is really important, because then you could involve them. And staff involvement and feedback is key, because they're the ones that do the day-to-day work. They come up with some great ideas that we don't think about, and it'll make their flow easier, and then they'll adopt a change a lot quicker. So I think that's a really key success thing to succeed. And then using PDSA, so really try it out with a little group of people, either one provider, any kind of change. I think just making sure that it works and having feedback from the data. And then, again, having the data to confirm that you're succeeding. And communication to all staff members is the key to, I think, any kind of success. Communications of failing and communication of succeeding, because I think as long as they're understanding that there's always the reason that we want to change is, of course, to improve our clinic and improve patient care. So communicating that, what has worked and what hasn't worked, I think, is a really key to success. Our future goals is, again, as we want to be the home in 2015 for our patients here in San Mateo County, to expand our panel size and have more patients in our clinic be seen, I think is a process that we're looking forward to, the challenge that we're looking forward to tackle. Expanding the panel management, so expanding the role of how we deal with our panels and how we deal with accessing health care to them, and then continue to expand staff roles in this role. And then this is a picture of some of our staff members that are also always very excited because of all the work that they've done. Thank you again.
Thank you, Evelyn. This is Sophia Chang again. For those of you, some of you have already started to post some of your questions in that Q&A box. I encourage you to do that. I'm going to go ahead and pose some questions to both Evelyn and Susan here. One is you talked a lot about some of the ways to engage the staff, but someone asked specifically about how do you deal with staff who are resistant?
So I think there's always going to be staff that's resistant, but I also feel that our clinic is so I think the first thing is if you prove that it works, then the resistance is a little bit harder, it's a little bit easier to break down. And then also really listen to why they're resistant. They may have a reason that you didn't think about because of their process. They had something that we didn't think about. So listen and acknowledge why they're so resistant. Of course, some personalities may always be resistant, but then I think if it's working for 90% of the staff, then it's a lot easier to help the 10% come on board.
So it sounds like that's how you deal with then some of the folks who want a specific exception. Is that all right? Is that right?
Correct. I think specific exceptions end up for failure, because if there's a specific exception for every person, then there's no process, and then again, it doesn't really work. I think that there's some a little bit providers may have some things that they want to do or that they work out with their team. Then I think there's some rooms for a little bit of not following exact process, but at the same time, I think it has to work for the whole team. So I may interact with my nurse very different than another team interacts with their nurse, but I think that within a team, there has to be very few exceptions to the process.
So a real logistic question here is how many providers are in your program, and are any of them residents in a training program?
So we have.
And how many FTEs of RN time do you have? Sorry.
So we have 4.0 FTE providers right now. Most of them are part-time. And for RNs right now, we have 3.5 RN FTE time, and we don't have any residents.
And someone else was asking about how feeling that the PCP panel size of 4,500 was large, and what is your definition of an active patient in the panel?
So an active patient is someone that's been seen in our clinic in the last year, so the last 12 months by the provider.
I think just to clarify, the panel size for one full-time provider is 1,000. And we really define an active panel. So it's patients seen twice in the last year would constitute your active panel, or people eligible for a panel. So the 4,500 is not a panel size for an individual provider, but it's the panel in total for the clinic with the 4 full-time providers.
Okay, a couple other logistic questions here. One is actually specific to the clinic. How do you manage the comprehensive services to patients with the many different languages?
So again, we have the healthcare interpreter network to communicate with our patients when they come see us, and then we could also use it if we need to call the patient at their home. And again, in our staff, we do have several people that speak the different languages as well.
Maybe explain what the healthcare interpreter network is for people who may not be familiar.
So the healthcare interpreter network is it's really a cooperative amongst public hospitals throughout the state of California. It is a video and voice interpretation system. And so what happens is, say I have a patient in my clinic who is speaking Mandarin. I need a Mandarin interpreter. With a few clicks, I can get a live Mandarin interpreter, and that person won't be in San Mateo Medical Center, but might be anywhere else in the state who's logged onto the system. So, and that really enhances the quality of interpretation, because so much of communication is actually not voice; it's visual. So in the cases where we don't have an interpreter on the network who's live, then the system rolls over to a contracted provider, and that would be voice only, and we can get virtually any language we want with that. But we have all kinds of providers using that. We have psychologists who use those, who use that system to do neuropsych testing. You know, it's used for a regular provider visit. It can be used for a nurse visit. So it's a really effective system that we use throughout San Mateo Medical Center.
There's a question here about describing, please, the meeting structure and who participates in those meetings and how frequently they meet within the ICC. And someone else is just asking for a little clarification on what those brown bags were.
So real quick, the brown bag lunches, where it's just the staff members bringing their brown bag for lunch, and the meetings would have, so those education meetings would be on their free time at lunchtime, where the provider and the staff would just go in the conference room and they would discuss whatever topic it is. So brown bag meaning bring your own lunch to this little education session. And then the other question was, sorry.
But how frequently do the staff of the ICC meet? Which staff? How frequently? How do those meetings run?
Correct. So first, initially we had the pods. So ICC in general we meet once a month, but then the pods were also meeting initially once every 2 weeks, once a week. Sometimes for 5-10 minutes in the beginning of the day, sometimes during their lunch break for 30 minutes to decide either a process or how they were going to communicate, or how the different things were going to be divided into the pods initially. Now it's really more of the medical assistant and the provider meeting 10 minutes in the morning. If there's a lot of nurse visits that day, then the nurse will come in real quick and then kind of go over the schedule. So now it's a daily, every day, the medical assistant and the provider really talk about their schedule right at the beginning of each shift. So 5-10 minutes in the morning, 5-10 minutes at 1 o'clock. It really helps the flow, and just to make sure different things are done before the provider goes and sees the patient.
And how do patients establish care at the ICC? Are there established lines of referral between the ED, urgent care, and ICC?
So there's different processes to establish care, but so the patient gets on a wait list and they get to be seen as just going through down the wait list, and then they get into a panel at that point. And every provider has different amounts of new patients depending on how full their panel size is.
And what other roles do RNs have besides working on the team? Do they, for example, also do triage for walk-ins, telephone advice, et cetera?
So each RN is in charge of all the patients in that team. So they do the triage for all of that team. So the patient calls, they have an option to leave a message for their RN for that team, and they speak directly. So all triage, all vaccines, all shots, all hypertension, all the different nurse visits for that team belongs to the one person. So they really do everything for that team.
Great. And is there a wait list for the clinic? And what is the typical wait time for an initial appointment?
So there is a wait list right now. We are hiring new providers, and so we're hoping to decrease the wait list. At one point, the wait list was a couple hundred, like 200, and now it's up to 600 to 800. And so we are hoping to get that down as soon as we hire new providers.
And one other question. There's a couple questions on patient experience, which I'm going to end with. And what percentage of your patients are uninsured? Do you have large numbers of homeless persons? And do you see a large number of people with severe mental illness or drug dependency?
So across our system, roughly about a third of our patients are uninsured, a third Medi-Cal, and a third everything else. It tends to vary from clinic to clinic. It's probably the percentage of uninsured at the ICC is probably a little higher, maybe closer to 40%. We do serve a significant number of homeless, and that's actually a target population for us, so we do significant outreach into the community to bring homeless patients in. And we absolutely serve lots of people with severe and non-severe mental illness and drug dependency, and that's one of the reasons it's so important to have the psychologist and our MedPsych consult team as a key part of the ICC. And in fact, we have behavioral health services integrated to one degree or another throughout our system, and that's a big focus of ours because it is such an important health issue for many of our patients.
I've got a couple of questions here about patient experience and patient engagement. So first of all, how important is patient engagement to you and this clinic in particular, and have you obtained any information on the patient experience so far?
I think that's probably the most important, because if the patients don't feel that they're being taken care of or don't feel that the staff is responsive to them, then really the communication from our patients to our staff is broken, and then whatever we do, whatever changes we do, is not going to really improve. So initially we did do a patient satisfaction survey, and it did improve. Then we haven't done it recently because we're going to adopt the Press-Ganey survey April, which we're really excited to start collecting data from that to hopefully show our patient experience.
And have you used any strategies so far in engaging patients or any specific information tools that you're using to help your providers in particular engage with patients?
So, I think part of the patient goals, that's what the patient, it's not what we have for the patients. So the patients come up with their goals. We really have our medical assistants communicate with our patients in that sense to help bridge the gap with the providers. And then the providers, again, emphasize that these are their goals and would set goals of what they want to do during the next visit. So, again, that's kind of the tool that we're using because it starts from the patient, and then it kind of is a little bit more meaningful. And our diabetic teaching, a lot of the times we encourage family members or whoever cooks to come to the nutritionist appointment, because if it's someone who's not the person who cooks for the patient, it may not be as helpful. So we really encourage family or friends involvement, whoever is a significant part of that patient's life.
The other thing I'll say about that is that last year, I mentioned the Seamless Care Initiative a few times. last year, the focus of that initiative in all of our clinics, including the ICC, was really on making sure we could get patients in. So we focused on time to third next available appointment and no-show rates. And this year, the focus of our initiative is really on exactly this, on patient engagement, getting patients, particularly with chronic illness, engaged in the care, and having specific champions at the different clinics who will be involved in a sort of a train-the-trainer kind of approach to make sure that we are using appropriate techniques to get our patients engaged in their care.
Great. And someone asked a real logistic question is, do you provide transportation for patients to ensure that they show?
No, we don't.
A couple other kind of staffing questions here. One is that you mentioned that you were in the process of hiring providers, and have you considered hiring physician assistants to be a part of the team?
So we do have a physician assistant and a nurse practitioner as part of our provider team.
And do you have a care or case management program?
Not specifically in our clinic.
Okay. And it looks like one of the local Bay Area teams is sites is interested in visiting your clinic. Who should they contact?
They could contact me.
Okay, I'll forward them the information.
Great, thank you.
So I think, if I have read correctly, that we've covered an incredible slew of questions. I'm not seeing any more come in. So I really, really want to thank both Evelyn and Susan for a wonderful webinar. We've got people still on the line who are really interested in what you've been doing. As I speak, I'm giving people one last chance to type in a question. But otherwise, I just want people to know that I'm going to take over this presenter thing here, that we will be posting both the slides and it's not letting me do this, both the slides and the recording of this presentation will be posted on the CHCF website. And our next call will be in 1 month. It's the 4th Wednesday of each month, and that will be, I believe that's April 23rd. I don't have it right in front of me. Hopefully you'll get a chance to join us then. We'll be hearing next time from the Clinica Family Services, formerly known as Clinica Campesina, and hearing about their transformative journey, which has been very interesting. So thank you, everyone.
Thank you.
Take care.